Hello, welcome. I'm happy to discuss pelvic floor disorders with you today, all of your symptoms and their connections. The goals of our talk today are to understand the different pelvic floor disorders in women, to learn how these pelvic floor disorders are connected and how the various pelvic functions are affected by each other, and to gain knowledge on treatments that can improve multiple disorders. So what are pelvic floor disorders? In general, women can have a weakness of their pelvic muscles or even tears of the connective tissue, and they can start to have problems with functions of the bowel, bladder, and vagina. Signs can include feeling or even seeing tissues come down or even outside of the opening of the vagina, which is pelvic organ prolapse. And these tissues can be various parts of the body, such as the cervix, uterus, or the walls of the vagina. You can also have issues with bladder function, such as urinary incontinence. You can have bowel issues with anal incontinence. With the bladder, there can be difficulties with emptying the bladder, which is voiding dysfunction. You can have overactive bladder, and of course, difficulties emptying the bowel as well, such as constipation. So to talk a little bit about pelvic organ prolapse, think of it like a hernia. It's a loss of support where things extrude out. And this is a herniation of these organs to or beyond the vaginal walls. As mentioned before, it can really involve any of the parts of the body down there, such as the uterus and cervix. It can be the top of the vagina or the vaginal apex if you've had a hysterectomy. It can be the front wall near the bladder or the back wall near the rectum. And you can even have some small bowel come through, kind of like you do in an abdominal hernia. With prolapse, you can have symptoms in many different forms. Most commonly, women with symptomatic prolapse have a bulge and a pressure. They can also have abnormal vaginal bleeding or discharge. They can have urinary symptoms such as incontinence, a slower stream, some trouble even emptying, which is retention, frequency of urination where they have to go all the time due to urgency. This can happen at night, which is nocturia, and infections. For the bowel, same thing in regards to difficulties with emptying, such as constipation. There's splinting, which is actually when you push up on the prolapse to help you empty. There can be an urgency with bowel movements, even pain with bowel movements, which is dyschezia or hemorrhoids. You can also have sexual dysfunction. In fact, women with not just pelvic organ prolapse, but any of the pelvic floor disorders we're discussing today, up to 70% of them have sexual dysfunction. So now I'm going to transition and talk a little bit about bladder symptoms and urgency. I'm sure some of you have had this experience where you have to rush to the bathroom. To review the normal function, the bladder is in general quite simple in what its function is. We fill the bladder with urine. This is filling and storage, and then we simply empty it out. When this happens, as we fill, the bladder is simply relaxed, and the urethra, which is the opening, stays closed so it doesn't leak out. And then without you even having to worry about it at all through reflexes in our body, when we're ready to void, that bladder itself will contract and that urethra will open so that the urine will come one way out through that opening. And when you have problems with either of these areas of storage or elimination, you can have several disorders. For instance, with storage, if there's a trouble with holding that, you can have overactive bladder, which is that urgency that causes you to have a difficulty emptying the bladder. Neurogenic bladder is when that bladder storage is due to problems of other diseases, such as nerve-based diseases like Parkinson's disease, issues with the spinal cord or injury. Interstitial cystitis is also called painful bladder syndrome, and this is when the bladder is uncomfortable, so it's hard to hold it. And intrinsic sphincter deficiency is when that urethra that normally stays closed as we are filling has trouble staying closed, so it will just leak out. With elimination, if you have trouble emptying, there can be voiding dysfunction or even retention. The bladder itself could be weak and be either hypotonic, which is a weaker bladder, or even atonic when the bladder has no function. It just can't squeeze. Again, neurogenic, the source of this could be some underlying diseases. Detrusor hypermobility with impaired contractility is when the bladder is spasming, it's contracting, but the contraction isn't strong enough to empty. And the detrusor sphincter dyssynergia is a disconnect. So remember, I mentioned when you're emptying, that bladder will contract and that opening of the urethra will open so it comes out. But if there's a disconnect where that doesn't happen, you can also have trouble eliminating. And there could actually be an obstruction, such as from prolapse, where their bladder outlet is obstructed to makes it physically hard to empty. When you lose control of urine, that's called urinary incontinence, a common problem with women. And my patients are very surprised sometimes when I tell them there's actually 7 different types of incontinence. To review those, stress urinary incontinence is that common incontinence we have, especially around pregnancy, when you do activities like coughing, laughing, sneezing, and you leak urine. And this is because there's an increased pressure that overcomes that pressure of that small urethra and the urethra that is typically closed. And so it just overcomes that and you can't hold it and you leak. It's most commonly from that urethra being more mobile than necessary, or again, that little sphincter, which is this circular muscle in the urethra that stays closed. If it doesn't work, it won't close very well and you just keep leaking because there's that opening is available. There's urgency urinary incontinence, and this is when you have the urgency to go and you just can't hold it. That gotta go sensation, primarily due to just uninhibited contractions of the bladder. And often we, again, call that overactive bladder. And when you have incontinence, it's overactive bladder wet. Overactive bladder dry is when you have those spasms with the urgency, the need to go often in the day or night, but you don't leak. Mixed urinary incontinence is any combination of these 7 types of incontinence. And most commonly, it's a combination of the stress incontinence and the urge incontinence. Overflow incontinence is when it just overflows out. So you just can't empty and it has to come out some way. So it does come out through that urethra. It can be from that obstruction we talked about in regards to prolapse, or there can be just that weakness of the muscle, of the bladder. So it just can't contract strong enough to empty. And then it just eventually overflows out, kind of like water spilling, overflowing in a cup. Functional urinary incontinence is when you really just can't make it to the toilet when you need to void. This can be due to physical or mental limitations. Transient urinary incontinence is a temporary leakage due to short-lived medical conditions such as constipation or bladder irritation, or even when you're getting treatment of conditions such as surgeries. When you're recovering, there can be some trouble with the bladder, or the use of sleep aids. And then total urinary incontinence is just complete involuntary leakage all the time, usually due to a fistulous tract, which is a connection between organs. So commonly in a connection between the urinary system and the vagina where there's just no stop point. So it just constantly leaks out. And so those are the different types of bladder symptoms you can have. And now we'll switch and talk about bowel dysfunction. Just like the bladder, we hold it and we empty it. And you can have trouble with emptying for various reasons, which I'll defer to Dr. Patel with her GI talk. But there's also fecal incontinence, which is really troublesome to women. And fecal incontinence, when you lose stool, there's also bowel or anal incontinence, which also includes gas and stool. And this is actually quite common. And it's amazing to think that at least weekly, up to 3% of the population will have these bowel incontinence episodes. And so looking at all of these pelvic floor disorders of prolapse, bladder, and bowel dysfunction, it's important to know that how they're all connected. By understanding how they're all connected, it'll help you to understand why you may have multiple symptoms. Why am I having bladder symptoms plus bowel symptoms? I have prolapse, and it's also affecting my bladder and bowel dysfunction. For instance, remember my earlier slide when I talked about prolapse and symptoms. Yes, from that dropping of loss of support, you can have that bulge and pressure and some abnormal bleeding or discharge, but you can also have these bladder and bowel symptoms that we discussed. And so how are these all connected? Well, there's 2 different theories, and one is a functional theory and the other is neurological. On a functional level, we've seen in animals as well as humans, when the bowel is distended, it affects the bladder activity and vice versa. Another example of functional theories of connections is bladder outlet obstruction and the effects of prolapse on overactive bladder symptoms. We know that all treatments for prolapse, be it either surgical or non-surgical, such as the use of pessaries to support the vagina, all result in improvement in overactive bladder symptoms. We know that women with improvement in overactive bladder symptoms after prolapse surgery show a better flow. So that shows you that obstruction or the outlet obstruction has been improved. We know there can be denervation of an obstructed bladder so that when you have that obstruction, it worsens overactive bladder symptoms. And so in general, with the detrusor muscle, when it's obstructed, it becomes more irritable, and then the synchronous activation can be damaged. Now, the neurological theory is really what makes me interested and excited. It's this cross-sensitization or crosstalk between the organs. In general, with crosstalks and cross-organ sensitization, you talk about just in general the nerve system. Our brain here in this illustration is really what coordinates everything, sends signals down through the spinal cord to different organs, and also receives messages from those organs back through the spinal cord and up to the brain so we can process it. This is how our bladder or bowel tells us we need to go to the restroom. And this is how in our brain we can say, well, wait a minute, I'm not ready to go yet, I can hold this. Or you can say, well, I'm gonna go on this trip, so I may not be full, but I'm gonna go anyway. There is also crosstalk and a coordination of these signals between the organs themselves, which bypasses the brain. And there are these sensory signals between the colon, the bladder, and the urethra. And so while these communicate, a problem in this communication or disease of any of these organs can result in disease in these adjacent organs. For instance, we see a lot of connections between bladder and bowel disorders. People with irritable bowel syndrome or inflammatory bowel disease. We also see problems with the bladder, such as overactive bladder and interstitial cystitis. We see people with dual incontinence, not just bowel, but bladder incontinence at the same time. And chronic pelvic pain also shows that, because you can have pain in many different parts of the pelvis all at the same time. And there's a lot of relevance, clinical relevance to this bladder-bowel connection, studies that have shown this, such as in chronic pain patients. They surveyed almost 3,000 patients with interstitial cystitis, again, which is called the painful bladder syndrome. And they have a much higher prevalence of bowel issues such as irritable bowel syndrome, colitis, and inflammatory bowel disease compared to general population who does not have IC. When they surveyed over 2,000 men and women in the United States with overactive bladder, they were significantly more likely to deal with bowel issues like chronic constipation and fecal incontinence compared to those without. And in studies of women with prolapse, they do see significantly greater levels of straining and bowel dysfunction compared to those without prolapse. And what I like about this is when you understand these connections, it's really amazing how you can get treatments, one treatment that can affect multiple issues. For instance, with prolapse treatment, like I said, prolapse treatment, regardless of if it's surgical or non-surgical, can result in improvement in overactive bladder symptoms. It can also improve bowel dysfunction. So with the overactive bladder, often when I have a patient who desires surgery for prolapse and they have some overactive bladder, very often we may hold off on any treatments and just see how the bladder changes. And they may not even need any medicines or any surgeries or procedures for the overactive bladder because things get so much better with addressing the prolapse itself. There are also treatments, as I mentioned, where you can do one treatment and get two outcomes and improvement. And you can do things to help both the bladder and bowel incontinence at the same time. You can change food and drink, avoid triggers that make things worse, and bulk the stool so you have less bowel control issues. Exercises will just strengthen the pelvic floor in general and help you with bladder and bowel control issues. There's medications you can use for both issues. You can do a bathroom schedule where you just have a scheduled time to void and have bowel movements so you have less accidents. And then, like I said, treatments such as surgery, and there's even nerve-based treatment, since this is a nerve-based issue in regards to the nerve-based theories of connections, where we can do one treatment and get two improvements. And one of my favorite examples and things we use very often in my practice is nerve-based treatments for bladder and bowel dysfunction and control. There are clinical treatments and surgical interventions. And percutaneous tibial nerve stimulation, or PTNS, is a clinical treatment we do in the office. A simple needle in the ankle near a nerve in your leg called the tibial nerve that feeds back to the bladder and the bowel. And people come in for treatment sessions and then maintenance. And without any surgery or any interventions, they could potentially get improvement in both their bladder and bowel function. A more advanced treatment is the implantable device, because the nerves that directly control the bladder and bowel, and also where they intercommunicate, is in the sacrum, which is the lower part of your spine. We place a simple lead to access just one of those nerves and stimulate it, and you can have complete resolution or significant improvement in your bladder and bowel incontinence with this simple one treatment. Now, I do this for women all the time for both bladder and or bowel control, but when we have patients with both problems, they are just delighted. This one simple treatment, and all of a sudden they have control of everything. I had a patient recently who told me she was so excited about the resolution of her dual incontinence. She was going to ask Santa Claus for underwear, because for the first time in 40 years, no more pads, no more diapers. She can just wear regular underwear and be a normal person. And that's it. That's all my talk in regards to the connections about bladder, bowel, and all the pelvic floor disorders. I hope that gave you some great information and a better understanding of your own problems. And I welcome questions or concerns, and certainly reach out to me if you have any specific questions. Thanks so much.